Hi, everyone. My name is Yao. I'm a Health Information Systems Evaluation Specialist with the Digital Initiatives Group at the University of Washington. Today, I'm excited to share how our team partnered with CHARESS in Haiti to design a machine learning-based tool that predicts interruption in HIV treatment using both routine clinical data and psychosocial determinants of health. Interruption in treatment remains a major barrier to HIV care retention in Haiti. Health workers are overstretched and often have limited time to determine which patients are most at risk of disengaging from care. Haiti's national EMR, eSanté Plus, captures the vast majority of clinical records, which gives us a strong data foundation. But psychosocial factors are still undercaptured, even though they strongly shape a person's ability to stay in care, especially in Haiti's persistent conflicts. So our goal was to bring these two data sources together to support earlier, more person-centered identification of high-risk patients who may need additional support. To build a more holistic picture of risk, we combined detailed psychosocial survey data with routine EMR variables such as viral load history, ART regimen, age, sex, and prior treatment interruptions. The psychosocial surveys captured social and behavioral dimensions like economic stability, education, food security, social and community context, and physical and built environment. And because we ultimately want a practical tool for providers, we also looked closely at which psychosocial and clinical variables were the most predictive. The goal was to identify a small, parsimonious set of questions that could be used for quick screening without adding unnecessary burden to clinical workflows. We explored three machine learning models: a random forest model with Gini impurity-based variable importance assessment, a conditional random forest model, and an XGBoost model accompanied with SHAP values. Each model was trained using the different combinations of psychosocial and clinical predictors, and we evaluated the models on multiple metrics, including precision, recall, F1 score, and PRAUC. What we found is that each model had distinct strengths. The random forest model offered the most balanced overall performance, but the variable importance assessment favored predictors with higher variance. The conditional random forest model captured the highest proportion of true IIT cases, making it very useful for early identification. It also had the highest interpretability across the three models. And XGBoost was able to model complex patterns, but was less stable in this context, likely due to the modest data size. So in the end, the real question wasn't just which model has the best predictive performance, but rather which model best supports clinical usability and trust and is also technically feasible. Because this tool will be used in real clinical settings, we built it around the WHO's core principles for ethical AI. We prioritized human oversight, ensuring the model supports rather than replaces clinical judgment. We emphasized transparency and explainability, preferring models with high interpretability and unbiased variable importance so providers can clearly see why a patient is flagged. We centered equity by developing the tool using Haitian data for Haitian populations, and by incorporating social determinants to reduce the risk of bias that can arise from relying on clinical data alone. And we focused on accountability and sustainability, working closely with CHARESS so this tool can be integrated, maintained, and iteratively improved within Haiti's national systems. Looking ahead, CHARESS will begin integrating key psychosocial screening questions directly into eSanté Plus, so these data can be routinely collected, expanding the tool's accuracy and relevance over time. We will pilot the IIT risk tool within eSanté Plus to evaluate usability, provider trust, and workflow integration in real-world conditions. We'll gather feedback to refine how results are presented and how they inform clinical follow-up. And we'll continue aligning our approach with responsible AI practices to ensure the tool is transparent, equitable, and genuinely supportive for providers. This work would not have been possible without our partners at CHARESS, the Ministry of Health in Haiti, and the broader University of Washington team. A special thank you to all the clinicians, data managers, and patients whose insight and collaboration made this work meaningful. Thank you so much for listening, and I welcome any questions in the comments or via the email shown on the screen.